Public. Order. Welcome to this morning's meeting of the Health and Social Care Committee. Our evidence today focuses on the important issue of progressing on the prevention of cardiovascular disease based on a recent report from the National Audit Office. We are joined today on the committee by Anna Dixon from the Public Accounts Committee, and I'd like to welcome you to our committee today, Anna. We will be hearing from two panels of witnesses. The first focusing on local delivery on the NHS Health Checks programme, and the second with departmental officials. Welcome to you all. Could I invite our witnesses to briefly introduce themselves for the record?
Good morning. I'm Dr. David Wrigley. I'm a GP partner in North Lancashire in a town called Carnforth. We have about 26,000 patients. We have 5 branch surgeries in the local villages, so it's quite unusual to have so many practices and over 100 staff, so it's a large GP surgery. I'm also Deputy Chair at the BMA's GP Committee, which oversees the national contract negotiations, of which we're undergoing at the present time.
Thank you. And Professor?
I'm Professor Sir Sam Everington. I'm a GP in the East End of London, 50,000 patients, with the flagship Bromley by Bow Centre with 100 different projects under the roof dealing with social prescribing, so the wider determinants of health. And I'm also a professor at Queen Mary University.
Can I start with you, Professor Sam, if you don't mind, or should I say Professor
Sam.
Everington? Are you sure? Okay, we'll start with you then, Sam. Could you briefly set out your experience delivering health checks in the communities you serve?
Yeah. So let me start by setting you the context. So in Tower Hamlets, 150 ethnic groups, one of the most challenging communities in the country. And you might say, well, how have we managed to achieve it despite that? And there are some secrets which I'm going to give you about how this happened. But the overarching theme to this is consistency and persistency. So we've had primary care networks for over 10 years. In fact, that's where the government got the idea from. Social prescribing, we've done that at Bromley by Bow Centre for over 30 years. And as CCG chair 10 years ago, I put it in every single practice. We have a local contract, one of the few areas in the country that has a local contract with the ICB to the tune of 2% of the NHS budget, which delivers a whole raft of different things, because it's not just the health check you need to look at in isolation, it's all the add-ons that are absolutely critical to getting the delivery. We, for example, finance every practice to close half a day a month and team train. So the receptionist will train with the GP. Now, it's that team training, for example, which makes sure that actually everyone of the members of the team are all working to the same goals and in the same directions. We have a big focus on quality improvement, so we invest about 600,000 in quality improvement in primary care to try and redress the balance between mass regulation and not enough focus on quality improvement. We have contracts which have targets which are manageable but create a certain level of pressure in primary care. So one of the things, for example, we've done is shifted virtually all type 2 diabetes on the back of this 11 million local contract with the ICB. City and Hackney have it, by the way. Very few other parts of the country do. We have a contract with the PCN which gives 70% upfront funding and 30% dependent on delivery. Now, we set a target that is stretched but it's deliverable. So we want people to deliver it, so we don't make it impossible. And we keep on changing it and changing the goalposts all the time to drive up health and drive out health inequalities. We have IT systems, so everyone has the same IT system across the whole front. We have a clinical effectiveness group a group led by GPs based at Queen Mary University that collect all the data from the 2 million population in primary care in East London, in North East London, crunch the data and then feed that back in real time into primary care to say what's happening. So we create a whole raft of dashboards so that any general practice primary care unit can see where it is delivering on a whole raft of measures compared to local GPs. Now, this is really powerful stuff. This is not performance management, by the way, but it plays to people's professional drive. If you see that you're not doing so well as your neighbour, guess what? You'll talk to your neighbour within the PCN and saying, what's going on? What's the secret? And that professional drive is really, really powerful. There's things like the social prescribing, absolutely critical, because you can do the health check and you can isolate what the problem is, what the matter is, but if you move to a social prescribing approach, you focus on what matters to you as a patient. So I could sit there as a GP and say, well, you've got heart disease, you need a statin prescribing, but actually I know that's not going to motivate most people. What you had to do is drill down to an individual, what matters to them, what's going to motivate them. And the social prescribers have been working in Tower Hamlets for many years to be expert coaches and focusing on this personalised approach. And it's completely opposite, by the way, to what we were trained to do at medical school. You diagnose something, you say what the matter is, you prescribe a drug. Hence, the problem we face now is the utter focus on prescribing, of which we're now seeing increasing dangers. So 1 in 5 people, adults in England are on antidepressants. Something like between 10 and 20% of admissions in over 65s to hospital is drug side effects. So I'm ranging and giving you an idea, actually, of this holistic approach which we take over a period of years.
So, Professor Everington, do you believe, because of this holistic approach, you have been able to bring on board some of the diverse communities that you have in Tower Hamlets, as I face in areas like Birmingham, to ensure that you've managed to get this uptake because of the way you've done things?
Yes, absolutely. And most importantly, that personalised approach. So you're seeing the person in front of you as an individual, not as somebody with heart disease, but very much as an individual. And you're working on what will motivate them, depending on their background, their family, their community, a whole raft of things.
We will be hearing lots more from you, but I do want to move over to Dr. David Wrigley. Have I got that right?
Yes.
Fantastic. Over to you.
Yes, and we offer a more traditional health check model. My community is not as diverse as Sam's community. We across North Lancashire and South Cumbria in a very rural population, as I said, and we offer the health check as it's prescribed with the nurse appointment for a 20-minute appointment, and we search our computer system and call people in and undertake the tests. Check the pulse, blood pressure. We'll take blood tests for cholesterol and blood sugars. And then we'll follow that up afterwards in a system that's very well regulated, and we ensure that we pick up all the patients. And if they need follow-up, and if their blood pressure's high or their pulse isn't not right, then we'll undertake further tests. The Health and Social Care Act in 2012 did outsource, as you know, public health and handed it over to county councils. And I think this is an area that you should focus on, because public health has been absolutely decimated. The budgets were meant to be ring-fenced, but they weren't. And we used to have fantastic public health teams in our localities, but now they're all remote and distant. And they would have done a lot of work around health checks and looking at populations and targeting the disadvantaged communities. So it's a real shame that's been lost, but we are trying. And our integrated care system, Lancashire and South Cumbria, have undertaken additional work as compared to other ICSs in targeting areas with additional budgets.
So I'm going to ask you a similar question. Your area is a unique area, South Cumbria and Lancashire, and you've managed to get above the average. What 2 or 3 things, you'll get to know me, I love numbers. What 2 or 3 things do you think in Lancashire and South Cumbria that you've done, not you personally, but the team has done to, to really help with this increased uptake?
Yeah, I looked into this, and actually, as I mentioned, the ICS did focus on population health, which is a particular department within the ICS, and they set aside some funding, despite very difficult financial challenges, to do what's called an enhanced health check. So not just the things I mentioned earlier, but they also looked at disadvantaged populations, targeted them through the primary care networks that we have in place across the ICS, and looked at additional factors around cancer risks, mental health, suicide risk, and additional health education. And that targeting has shown improved results around better treatment of high blood pressure, better cancers picked up earlier in deprived populations, and also treating irregular heartbeats, which can lead to strokes and heart attacks. So that has happened in our area. It's led by a very, very good GP called Dr. Andy Knox, who's led the population health team, and it's been a real success. But that's despite the challenges they've faced in the financial climate that we have now.
Well, I'll stop you there, and what we'll do, we'll move to our the first person who will be questioning you. Can we go straight over to Joe Robertson?
Hello. Can I ask, what was your experience in the provision of follow-up care for those who are identified as high risk following a health check?
So the magic of general practice is we offer personalised care. We know our communities, they know us. We've obviously been there since for decades, and we are able to. And we're trusted as well. Patients trust us as GPs in their local surgery. They know the staff really well. So contacting them and following them up is made easier because they know us and trust us and want to come and see us. So if we identify patients who have a high cholesterol level or a high blood pressure, or their blood sugar levels are high, then we'll call them back and ensure that we treat them, and that's done through a computerised system. General practice is way ahead in the NHS on IT. We've been computerised for decades, and our systems are, they're full of all the health information, actually, that many external organisations and other companies would love to get their hands on, but we're very careful that we treasure and maintain that confidentiality. So we do follow them up, but with the outsourcing that's occurred, I know in my particular area in Lancashire and South Cumbria, there are other organisations that are undertaking health checks, and it's rather disjointed, and it's done and often with a finger prick blood test, and that is not as accurate, and it does cause us concerns. I've had patients come to me asking for an urgent appointment because they were told their blood cholesterol was really high on a finger prick, and because it's not as accurate, we then have to undertake a repeat test. It's not high. The patient's undergone a lot of anxiety and concern, obviously duplication of work and tests. And this is not a good way of utilising resources. As I say, I think it needs to be focused down into the communities, into the PCNs and the practices to undertake these tests. And there is an ability to do that within the GP contract through what's called enhanced services. And you could ask NHS England to produce one for across the country, and that will be funded through general practice, audited and undertaken by the local surgery.
Thank you for.
Yeah. Are there any specific gaps in follow-up pathways that you think might hinder the prevention of CVD?
I think the gaps are around, this is what I mentioned, the outsourcing, and I asked colleagues on our committee, which covers the whole country, we represent GPs across the country, 60 members, and the answers I got back on our group were just mind-boggling. The differences across the country, it was just so many different ways and things that are happening that are disjointed and not joined up, and patients will fall through the nets if that happens. So it's about having national coordination. Things like this need national coordination, a national directive, and not allow areas to do things differently and undertake it, with these outsourcing models, which lead to very disjointed care. And the NHS is far better to do that on a locality with that national direction.
How do you see that national sort of coordination being rolled out, embedded in practice? I mean, if it was easy, presumably it would have sort of happened organically. Yeah.
No, it would require a contractual model, but that's fine. That's very easily done, and we're through what I call the directed enhanced service through the GP contract, which every GP surgery across the country works under, and then the NHS England will provide that and offer uptake, and then that's audited and measured, and you can extract the figures and show the improvements. So that would be a good way of ensuring that the model is rolled out in in a way across the country that it doesn't leave a sort of a postcode lottery in effect.
Is it possible, Sam, have you got any thoughts on this?
Yeah, 3 thoughts. Firstly, the local contracts are really important. And I think if the government is going to be successful in this shifting into the community and the prevention from illness, what you've got to do is almost set a target for each ICB to increase the funding for this by 1% every year for the next 5 years. You've got to be disciplined. At the moment, our ICB and many ICBs are not controlling the acute sector budget, which is actually the least productive part of the system. Primary care is the most productive. Last month of records, 40 million consultations in primary care. That's over double the population of this country seen in primary care in a year, which, by the way, gives a fantastic opportunity. It's what Tesco's or any other business would die for, that footfall, that opportunity. While you're here, I notice that. And this is the power of primary care. But we also need support services actually for patients. So in Tower Hamlets, swimming is now free for all women over the age of 16, all men over the age of 55. And you might say, why is it better for women than men? The answer is life expectancy now is lower in women in Tower Hamlets than in men. But I asked the question, actually, why couldn't this happen in every swimming pool in the country? That on the whole is substantially empty quite a lot of the day. So it's the added services that's really important. It's the holistic approach I talked about, the social prescribing. Look, one of the things that can really help somebody with heart disease is to have a job. The worst thing you can do them is to sign them off sick. We now are the sick note capital of Europe, with 2.8 million people on sick notes, above elsewhere. So that actually our social prescribing approach, my longest consultations actually are with people who are asking for a sick note. Because I know actually if they get into that sick culture, a deconditioning culture similar to what happens in the elderly, that's a disaster. I know that somebody with diabetes and heart disease, the best thing they can do is around activity. And the best thing they can do often is actually good finances within the family so they can buy healthy food. So these sorts of things are really important, but what nationally they can do, and this maybe is you give a challenge to the people from the Department of Health later on, is if you're serious about making these changes, these shifts, then set a very simple target actually for the ICBs. And also ensure that the acute sector is kept within budget like primary care is. We have a fixed budget. To the point, I can tell you 7 years ago, I had no pay for 5 months because we hadn't set our budgets correctly. That's how powerful it is in primary care. But my overarching message is, not just because I'm a GP, the potential in primary care, the increase in productivity since COVID, up 20%, with less GPs and less money, there's a very key message here. Far more investment in acute, far more consultants and specialists, by the way, being created, and yet virtually no change in productivity. And the final thing is our ICB is very innovative. It's given us a population health budget for 50,000 patients of $250,000 in our APMS contract. That's the only APMS contract that has got that in the country. This should be the norm across the country.
Thank you for that. Can we move swiftly on? Over to Danny.
Thank you very much. Thank you both. So the NAO report, which is the focus of today's meeting and is kind of motivation behind today's session, particularly highlighted failings around the patient journey and data sharing arrangements, a kind of lack of, as you were reporting, Dr. Wrigley, a lack of providers being able to kind of connect with the broader system, that data, once checks have been carried out, not flowing back into primary care records and necessarily leading to effective follow-up for those at increased risk. I wanted to understand more about your experience. I think particularly, Sir Sam, you're highlighted, Tower Hamlets are highlighted in the NA report as the example of good practice around data sharing. You've touched upon some of the underlying principles of data analysis and sharing in your PCN already. So I'd like to get both of your perspectives about how that principle of data sharing, enabling an effective patient journey works in your system, if that's okay. I don't know if we'll come to maybe Dr. Wrigley first and then...
Yeah, so I mean, the NAO did raise concerns, didn't it, that these checks were not working effectively, and I think they questioned whether the local authorities were the best providers for this, but that's in the context of public health spending falling, particularly since 2015, which I referenced earlier around a need to focus on public health. But with the use of data, it's so important that's done properly and effectively and also safely. There has to be good governance around use of data and how that is shared. There is an easy ability for external NHS organisations from the practice to view the GP record. The software is in place. It's called GP Connect, and it's called GP Connect View Record. So in effect, it opens up a window. If you were in A&E or in the outpatient department, your clinician could open up that window on the GP record and look at your figures and stats, and that allows you then to sort of take the care forward. But there is a move to try and take health checks into a digital world, so you could go on the NHS app and undertake a health check. Now, we have been approached by NHS England, the Department of Health at the BMA. We have a committee called the Joint GP-IT Committee, full of experts from the Royal College of GPs and the BMA. And we do have concerns around that digital health check, in effect that it does what I mentioned before, that home blood check with a finger prick, and the concerns over accuracy and how that could further cause anxieties for patients, but also lead to duplication of work. So it comes back to what Sam was talking about, that personalised care in your local community with a practice and team that you trust and recognise, and ensuring that takes place in that community, because we need to do more of these. We've called in about 2,000 patients last year. We've got about a 25% uptake, but this is in the context of general practice really struggling, and obviously that's in the news at the present time.
Just to challenge that assumption, yeah. I picked up from your previous comments and what you just said, a kind of hesitance for other providers to be involved. You called it outsourcing, and just their kind of concern about a digital version of the health check through the app. As you highlighted, the capacity in general practice is limited. You're only reaching 25% of the 2,000 you reach in. There's an aspiration over 5 years, I think, to reach 100% of the population. We're far off that. Wouldn't the only way of actually moving towards that be to widen up the range of providers, to be working with the broader primary care infrastructure, pharmacies, be working with community-led organisations to reach perhaps those not registered on GP practices?
I think in this context, when I mentioned it, it's around doing these home checks and the home tests, which there is no sense that these are accurate enough to undertake this at the present time. If it was other aspects that didn't involve blood tests, then I think that could be possibly a way forward. But you need to take a blood sample from the vein in the arm to get an accurate test, and that's why we're not Luddites and saying this shouldn't happen. It's ensuring that it's done correctly and done accurately, so the patient gets the right treatment and the right results, and we don't have duplication of effort, and using the funds in the best way possible as well. And it does come down to funding, because we have to pay staff and pay for all the equipment required. So if this was funded in a better way, then there would be better uptake, because there'd be more staff able to call the patients in, ensure that they turn up, and make sure that the follow-up occurs as well. So we are trying very hard to do that, but in the context of a very strained system due to difficult finances and lack of staff. We've lost 1,200 GPs in the last 10 years. So we're doing more with less. Yeah. But that's why our current actions that we're undertaking is about improving patient care, getting more GPs, bring the family GP back, and improve general practice, because we used to be the jewel in the crown of the NHS. So that's not.
I guess my point was broadly from a patient perspective. The GP is important, but it's not the only part of the system, and many unfortunately won't access GP care, and so perhaps a range of providers is helpful to reach beyond those you already reach. Again, just to clarify, you mentioned the GP Connect app, so other clinicians can view that. Can community providers use GP Connect? And in terms of this data flow issue, is it possible for them to enter data on GP Connect or just view it?
So there is, it's a piece of software that it attaches to the system, and yeah, pharmacists can see that and view the record. Yeah. There's another aspect called GP Connect Update Record, which allows others to add into the GP record, but there are further concerns about that because as a GP, you've got limited time with a patient. You've got lots of information being pushed in from other areas. You can't see the wood for the trees, and also you have this issue where it could lead to complexities that you just don't want to see within the consultation. Diagnoses are added externally by perhaps a private provider. Prescriptions are added, and once that happens, the GP is responsible, and it leads to all sorts of concerns around governance and who is responsible for overtaking the care going forwards when someone else is added into the GP record. So this is not GPs being paternalistic and saying we don't want others involved. It's about protecting the patient's record, ensuring confidentiality, ensuring accuracy, and ensuring they get the best care possible without other things clogging the system.
How does it work currently in your system? So that's not used. Currently, those external providers carry out checks. How does the data flow back to primary care records?
At the present time, it can come back. It can come back electronically, but it can be by email as well. So, but then that has to then be transferred into the system. So
there are issues there with people's records not being updated, and they may be at high risk of cardiovascular issues and not followed up. Or
I mean, we know when information comes into practice, we don't miss putting that onto the record. So, but whether the provider's sending it or whether that information is sent through, that's obviously not our responsibility because it's done externally. We don't know that they're being done.
Thank you. And so Sam, as I mentioned, Tower Hamlets is mentioned in the NA report as somewhere where data sharing arrangements are in a good place. I don't know if you've got any reflections on.
So probably for about 10 years, we've had the East London Care Record. And the practical reality, that means the patient's in front of me, I can see everything that's going on in the hospital that's important for them. Their MRI result done yesterday, I can give them the result. Hospitals often said, well, we'll tell you in 2 weeks' time. So we've got all that information, all their blood tests, that's all downloadable into your records. And added onto that is something called the Discovery Project done by Queen Mary University, which then mines all the other information, adds it in and creates a fantastic knowledge base, actually, academic knowledge base, which feeds back information and advice to the system. The second IT thing, which is really important, is we've been heavily involved in the development of a system called AccuraRisk, which most general practices now have in the country. It's a tag-on to the EMIS system that all our practices use. Now, what does AccuraRisk do? You see, one of the best ways of motivating and involving people is actually to engage the patient. Obviously using the NH app to access their information, but also to input information. So any patient, by the way, with our AccuraRisk system can go online, brief us. There are simple questions. What's the problem? What have you tried? What's your expectation? Who do you want to see? And they often write a half a page for us. That's fantastic and should be, I think, universally across the country. It does two things. Firstly, it briefs us properly about what the issue is, and it encourages patients to think more deeply about what is it they want, what is it they're worried about, what matters to them, rather than sitting on a phone at 8 o'clock in the morning in a long queue getting an appointment. So it's a completely different approach. We can then send a text to a patient, for example. So all our patients now are measuring their own blood pressures. Much more accurate. You come and see the doctor, your blood pressure is going to be up. Actually, you measure it at home when you're chilled, much more accurate. So we can send a text to the patient. For example, it's called a flurry, which allows them to send their blood pressure reading coded into their notes every day for 7 days. Now, that's just one example of what can be done within the system. But engaging the patients in managing their own care is absolutely critical to this. We know, one example I'd give you, if patients measure their blood pressure, if they've got a blood pressure machine, their blood pressure, the research has shown, is 5 millimetres lower. And it doesn't matter where you look, engaging patients, supporting them to manage their healthcare will give you far better outcomes.
I mean, it sounds really positive. I'm just wondering why that isn't common practice. I mean, you've been highlighted in terms of data sharing arrangements as overcoming some of the barriers to the health check system in terms of data sharing arrangements. How have you locally been able to navigate the barriers that other people face where there isn't data sharing arrangements in place between health check providers and primary care, between the local authority and primary care?
It's a lot of what I mentioned before. It's a cultural shift over many years. It's a bit like the 10-year plan. This doesn't happen overnight. And you nudge it in all sorts of different ways. To the group training, which I talked about over a period of time. So there's not a simple solution to it. But if you want drivers to it centrally, there's a whole raft of drivers around IT, for example. I mean, the Accurus system, people should be incentivized. I mean, there's been a great focus, for example, on the 8 o'clock, the pressure at 8 o'clock and not being able to get through on the phones. And so centrally people have said, well, we've got to improve the phone system. No, that's a bit like going back to faxes. If you get 85%, as we do, to go online and brief us, actually that gives fantastic support to the 15% who are not digitally very, very good, and they can get through at 8 o'clock on the phone and throughout the day. The other thing which is really important is the centrality of primary care in delivering on these outcomes. Really interesting. We had some of the best flu vaccination rates in the country. That has slipped. Scotland has got even worse. Why? Interestingly, because they gave more opportunities to get your vaccinations elsewhere, which dilutes that population responsibility. So you have to be really careful. On the one hand, you can argue that actually what we need is a lot of different mechanisms of getting these checks. But it's really interesting if you take away the key responsibility from general practice, and I'm not just talking about GPs, because we've got pharmacists, we've got physiotherapists, we've got an incredibly wide and amazing team in primary care now. If you take away that prime responsibility, there's a risk that actually your targets drop. And that's counterintuitive. But the incentives from the centre, absolutely important, and sometimes very minor financial incentives. General practice is very fleet of foot. You give a financial incentive, and guess what? They'll deliver, as was shown in 2004 in the contract, and as I can guarantee you will be shown now with the £20 for advice and guidance. That money will be spent very, very quickly. So there's incentives there, and then exactly as you said, actually getting the sharing of this information within systems, absolutely critical.
Can I just quickly add on the IT, that is happening across the country, the AccuRx, and the ability for patients to SMSs, and we use the NHS app and they can send us blood pressures or the other measurements. So that, to reassure you, that it's widely, since the pandemic actually.
So I guess just to challenge you back on the point, you had concerns about healthcare providers entering patient data and the accuracy, but the system's moving to allowing patients to enter blood pressure measurements. I just point out, if a community healthcare provider, a voluntary sector organisation, a nurse, a pharmacist has more medical training, surely they should be able to enter.
Mine was about the accuracy of the finger prick and how that can cause undue anxiety because it's not accurate.
I think,
we've got
I don't want to kind of revisit it, but I think you were suggesting that you were concerned about the accuracy of data from other providers feeding back into the primary care system. I guess I'm just pointing out that the system's moving to allow patients to, and I support that personally, but that would seem kind of counterlogical that other trained healthcare professionals...
So it doesn't drop straight into the GP record, it comes in a pop-up on the screen and then we interact and save it to the
system
record.
Might be possible then to allow other providers to enter data.
It could be possible. There is another final point that's really important. We assess patients on our system with called QRisk, QRisk2, and that puts information in around blood pressure, age, cholesterol, and it gives you a risk score of stroke and heart attacks, and there's 8 million of those done every year, and there's a new one called QRisk3. It's not been rolled out, and it's been around for 7 years. It's got highly well-respected academic rigour, and we've written to Amanda Doyle at NHS England to say, look, we need this in our GP systems to offer better ability to assess patients. So QRisk3 is something that we really need to see rolling out.
Just to come back to you on that, As she made a statement as to why it hasn't been rolled out, is it because of finances? Has she actually said what needs to happen for it to be rolled out?
It's almost like a standoff at the moment. The IT specialists, the health informaticians know it needs to be in there. We've got the computer systems are run by two large companies, mostly across the country. They need to put it into their system, so it needs people to come together and get it sorted. We know it's the right thing to do, but it needs some maybe pressure from yourselves would be helpful.
As a committee. Thank you for that. I want to bring in Dr. Becky Cooper, who wants to ask an additional question in this area.
Yeah, thank you, Chair, and thank you both for coming. So I should declare that I'm a public health consultant, so I have commissioned NHS health checks. So I just wanted to ask your thoughts, really. It's interesting to hear you talk about GPs, and I'm a big fan of GPs, they're fantastic, but when I tried to commission health checks, there were issues around capacity in general practice, and there were issues around how many GPs I could get interested in actually commissioning health checks. And I am a medical doctor myself, and I understand the pressures of primary care. So, whilst I'm all for allowing primary care to be a real heart of a community and family doctors, etc., I have concern that if we put too much onus on primary care, that we may miss out on other opportunities with pharmacies, etc. So just listening to what you're saying, I just wondered if you could respond to that. Thank you.
Obviously it does.
Before you respond, can I apologise, because I should really have brought in Mr. Greg Stafford. Do you want to ask an additional point to that, because that was the area you were asking on, or do you want me to get?
Well, I think I'll let because it's very better if
just so that we're clear. Okay, over to you. Thank you.
Yes, and I think it does come down to the resources and the ability for general practice to undertake this work. And as I've already stated, we have less GPs now. There is a new scheme in place from the Secretary of State around more GPs in general practice. The scheme is quite inflexible. It has issues that we need to deal with, but we need to get more nurses. It's not just about GPs, of course. The whole team is important here: nurses, primary healthcare workers, and social prescribers and others. So it's about boosting up general practice and getting the staff in there. Then we can do more. As Sam said, we are very fleet of foot. We have a very flat management structure. We're the only part of the NHS that doesn't have a deficit. We don't run deficits. We can't do that because if we're bankrupt, we can't hold our contracts. So, that's why general practice absolutely needs to be focused on, invested in, and we'll do more. We do more and more if we're given the opportunity to do so. And it follows on, if you provide the funding and the staffing to do these health checks, more of them will be done and undertaken, and more diseases will be prevented. But it's about getting that staff into the community, and that trusted practice in the community, known by patients, so they're more willing to engage with than perhaps an external provider.
Becky, has it answered your point?
Yeah, absolutely. I'll let Greg carry
Brilliant.
on. Thank you.
Can I go straight over, please?
Thank you, Madam Chairman. So my questions are around some of the stuff you've already touched on, but I think to bring it together, could you just explain briefly how your systems were commissioned and managed, and what impact do you think the way that they were commissioned in your area had? What impact did the way that it was commissioned have on service delivery in your area?
So it's commissioned through the local authorities, so Lancashire County Council, and they offered the package, and obviously they've also outsourced it as well to other providers. And as I say, we use our system to find the patients. We call them in. They get a 20-minute appointment with a nurse where all the health advice is given, blood tests are taken, blood pressure and pulse are checked.
Sorry, I didn't mean to. My question really is around. Obviously, there are lots of different commissioners within the NHS for these checks. Yeah. Obviously, yours was commissioned through the local authority. What impact, negative or positive, did that have in the way that you were able to deliver the service, as opposed to if it had been commissioned in some other way?
I think it's so disjointed, and as I said, I've asked the committee around the country, and there's so many different systems in place and contracts being offered. It's a real mess. It's a complete mess of what's going on, and that's why I talked about having a national contract offered, for this, and that would allow it to be undertaken across the board without that postcode lottery, because people are falling through the net here. I know in the North East, a colleague said that it's really because the funding isn't adequate, you know, it's really difficult to get people on board. And if you provide that national contract with adequate funding, then you'll prevent more illness, prevent more strokes and heart attacks. It's about encouraging and nurturing and boosting up general practice.
And so Sam, your experience?
Yeah, so the key, I think, to our success is clinicians, managers and patients working together on the commissioning process. Absolutely vital. And when I think of all the things we achieved over the last 15 years, the clinician engagement, absolutely critical. So one of the first things we did 15 years ago, rather than sit there as commissioners and says, well, this is what you've got to do, we're going to put money behind it, we actually went to general practice and said, what's worrying you? What's your biggest concern? And they said, actually, diabetes, which is a massive problem, particularly in our Asian community in East London. And so we focus there. But it's the engagement. And as I say, when you get those three groups working together, commissioning, that's when you'll get the highest success rate. And if I see anywhere in the system that's not working well, what I see is clinician disengagement in population health, in managing the finances and in managing a system. So therein lies the secret. And it's been quite organic. And yes, there are drivers you can set centrally, but it's the sense of ownership by the local systems that will actually make it really happen.
Am I sensing a disagreement between you two in terms of how the Commission, you seem, Sir Sam, you seem very focused on sort of the local element, whereas you, Dr. Wrigley, seem to want a national system?
You know, I think you could do both. The national obviously then goes down to the local area. So there's a national contract to offer the health checks, but then the localities take ownership through the ICBs, and also, you know, focusing back on public health, which, as I say, has been completely eviscerated in localities. You would have had public health teams focusing on this in their localities. They know the areas, they can focus on the deprived populations, and that just isn't there anymore. So, you know, that national directive with local input from the practices and the clinicians and staff who know them best, it works perfectly well.
So there's something about a national contract to give stability in primary care. But I think if you're going to get this extra traction that we all want, it has to be a local contract. Otherwise, there's a risk that the ICBs just say, well, actually, primary care is not our responsibility. It's done centrally. And then you don't get that creative transformation where an ICB will say, actually, here's our problem, a very specific problem we've got locally, whether it's type 2 diabetes or whatever. How do we shift funding from the acute to primary and community actually to make a real difference with much better value for money? Let me just give you one example for the value for money I'm talking about. Roughly, to see a GP, complete episode with all the back office costs, about 25 quid. That's peanuts. And I used to be a lawyer, and I can tell you what I used to charge at work. You know, a big, big difference. 10 years ago, I asked my finance director of the CCG when I was chair, I said, can you please tell me what's the equivalence if somebody lands in outpatients? And at that time, he said £628. So anything you can do to keep things out of the hospital, anything you can do to focus on prevention is going to be much better value for money. But if you have an ICB that traditionally is just kind of bailing out the acute sector all the time and is not using its creative muscle to think value for money consistently and the taxpayer pound, you're not going to get the change. And yes, a central contract to give that stability and not to have to duplicate. You don't want ICBs to duplicating most of the stuff that's in a national contract. But actually that sense of local ownership and responsibility, absolutely vital.
Okay, I think that's very helpful. Finally from me, you've talked about the incentives and the barriers, but in terms of how providers of these health checks are incentivised, would you suggest any changes to the incentivisation or reward schemes to encourage higher uptake? Don't mind who goes first, Dr. Wrigley.
I mean, the funding we get at the present time is £30 per health check. You know, as I say, that's for all the work in finding the patients and calling them in, and then the 20 minutes of nurse time, then the follow-up. So, you know, that it isn't a lot of funding. And if, you know, we need to look at and address that really to increase the uptake. What the other providers get.
So how much would you like to cut it down?
I wouldn't want to put a figure on that. I think we'd need to have a discussion and negotiation around that.
I won't make you do contract negotiations in public, but
it needs to be balanced, doesn't it, against how much illness are you preventing and the work done. So you know that's again where public health comes in and economists. But happy to have a discussion about that. But it's clearly inadequate at the moment.
I'd like more funding for social prescribing. So if you think of determinants of health, it's about 80% is social, 20% is the traditional biomedical. But in this sort of territory where actually you have to provide a very personalised service to you as an individual, depending on what matters to you and what motivates you, social prescribers are absolutely key. And they're not just link workers or connectors. They're actually, I've described them as highly emotionally intelligent. They like people. They're motivational coaches. They know what's available in the local system, but they know about it in a real way, not in a Google way. You can Google the swimming pool, but actually, I swim every day. I'm able to say to my patients, and the social prescriber can do the same, is, when's the time, look, if you're not body beautiful, when's the time to go where actually it's not going to be many people there? Who do you talk to when you go through the door? Talk to Jane. It's that personalised approach that's really, really important in all of this. And that's where the social prescriber comes in with that unique personalised knowledge.
Thank you very much. And I would never describe myself as body beautiful, but it's a phrase I'll take home with me. Thank you.
Well, I'll take ownership of the word if he doesn't want to. And on that note, can we go straight over to Dr. Anna Dixon, who just wanted to ask a final little point.
Yes, thank you, Chair, and thank you to both the witnesses. I will just declare a conflict of interest that I've known Professor Everington in a professional capacity for some years. So one of the things we haven't touched on is the fact that NHS England is spending a lot of money on some national programmes, weight management, diabetes prevention programmes. We've also seen through the public health grant actually a reduction in the amount of money being spent on smoking cessation services. So when we come to this idea of follow-up, so obviously key to the success of this health check programme is not only that people attend them, that you through that actually detect those that are at higher risk, but that follow-up happens. And some of that follow-up is sort of sits with doctors. You can write a prescription for statins or hypertensives. But as I think perhaps Professor Everington, you were describing, really for a lot of people, the follow-up is about behaviour change, whether that's to diet or physical activity and so on. So really I'm trying to understand, how are you connecting health checks into the money that's being spent by NHS England on these centrally commissioned programmes? And could we be getting better value for money in terms of the support available for follow-up? Whether that be an increase in the public health grant for smoking cessation, for example. So perhaps start with you, Professor Everington, and then hear from Dr. Wrigley, if I may. Thank you.
So the public health grant is really important and should be ring-fenced. It's well worth looking at because it's completely variable across the country. When we became a CCG and the local authority took over the public health grant, we gave them the top grant in the country. So there's something about actually looking at that grant, but also looking at what it's spent on and then protecting it. Because local authorities, like ICBs, are under massive pressure in all sorts of directions. And it's very easy for money to be taken out of these, how most people would see, low-hanging fruit areas. You know, the temptation is always the winter crisis or kind of the immediacy of any crisis. But actually, unless you do ring-fence this, it's a bit like ring-fencing social prescribing. I would say you need to do that in primary care. Really, really important because it's a new and developmental area. That's crucial. I think the national scheme's helpful, don't get me wrong, and I think they've driven a change, but I think that's about taking local ownership. And my final point would be cautious about the biomedical approach. The drive now for everyone to have Mounjaro and all these injections is enormous. We have no idea of the long-term effects. And yet again, we're seeing biomedicalisation and the drive, whereas actually going back to what I'm talking about all the time, that personalised approach to an individual. You know, it might be that what somebody needs is a dog to walk every day. That is the thing that's going to get their weight down, get them motivated to change their lifestyle. There is a key issue with the local supermarkets. I live in social housing locally. I shop in the local supermarket. You see what people have in their trolleys. It's just appalling. Most of what you see in supermarkets is not food. They call it ultra-processed food. No, it's not food, full stop. And then there's widely held, so tackling and supporting patients in their managing their finances is really important. There's a widely held belief that healthy food is more expensive. Well, if you see the trolley full of Coke and cakes and biscuits, I could spend the same money and give a really healthy diet for the whole family. And then finally, pay attention to schools. Really, really important. We would like to see a school nurse in every school, not just doing heights and weights, but actually managing proactively the health, the social, physical and mental health. Children often get forgotten in this whole process, but that is where the ticking time bomb sits. When I trained as a doctor all those years ago, type 2 diabetes was a disease of the elderly. I got teenagers with type 2 diabetes. This is the ticking time bomb, and this is not just about adult health checks. There has to be, in every school, like in Norway, where I come from, healthy food every day for lunch, exercise, complete focus on health. It's 15% are overweight in Norway. It's 60% in this country. So go back to the prevention, go back to schools. Ask yourself why there's only one nurse in every 6 schools. Shouldn't there be one in every school? And shouldn't they be on every governing body?
Right, I am going to have to stop you there. Sorry about that. Can I thank you very much for giving evidence? No. Can I thank you very much for giving evidence today? And what we're going to do is swap the panels quite quickly. So thank you. And Professor Everington, excellent, and Dr. Wrigley, excellent, and we'll speak to you soon. Thank you.
Thank you, Tom.
Thank you very much.
Very much.
Yeah.
Thank you for appearing before us today, and I'd like to ask you to briefly introduce yourselves. Over to you, perhaps ladies first.
Thanks, Chair. So I'm Jeanelle de Gruchy. I am the Deputy Chief Medical Officer for England, and I'm the professional lead of the Office of Health Improvement and Disparities within the Department of Health and Social Care.
Good morning, I'm Jonathan Marron. I am the Director General for Primary Care and Prevention at the Department of Health and Social Care.
Thank you. I'll start with just asking you a few points. The NAO report compares health check attendance against the eligibility. The Public Health England said local authorities should aim for 75% of the eligible population to attend over 5 years. My question is, what is the department's targets for health checks? And that's over to you, Jeanelle.
Chair, if it's all right, could I do a slight step back and talk about health
what
checks
you can do,
within
what you can do without me reading the question is give us an update.
Yeah.
Then tell us where you were at, and where you're hoping to get to. Is that simple enough?
Yeah, thanks.
Thank you.
Because I did want to situate the health checks programme, which is an excellent evidence-based programme within and why it's important, if that's all right. Because cardiovascular disease has huge health impact. It's the second biggest cause of mortality with England. So 1 in 4 of our deaths are through cardiovascular disease. And it's a real disease of inequality as well. So those in the most deprived areas are more likely to die young from cardiovascular disease. In the most deprived, 4 times more than the least deprived. So it's a really important driver of the gap in life expectancy. And also we know that a third of new cases are in working age people. So we've got a huge issue, but at the same time, we know that we can do something about it. So we've seen the trend in cardiovascular disease come down from the 1960s. It's about 5 times less that's, of under 75 cardiovascular disease. But we also know that it's stalled within the last 10 years. So a real concern if it's preventable, and about 70% of risk factors are modifiable, then the question is what more can and should we be doing, which to your point.
But also, could you put into that, why is there less than half the population actually attending these checks?
Yeah, so we'll come to that. So we've got a lot, and I heard the previous speaker talk about all the primary prevention efforts, and those are really, really important in terms of, over time, having brought that premature mortality, that early death from cardiovascular disease down within the country. But at the same time, we need to do that secondary prevention. So we need to find people who are at higher risk, and we need to engage with them, talk to them about, we need to invite them in, and they need to understand why it's important for them to attend. They need to actually be able to come and take up the opportunity to have that conversation. And then the conversation and the way in which we engage needs to enable them, empower them to actually do something about those modifiable risk factors. So the health checks is a really important program to do that. It's evidence-based, it's at scale, it's systematic. But there clearly are issues in terms of that, as you say, who's been invited, that systematic invitation, and the uptake, who's taking it up, and then consequently how they are modifying those risk factors which I've talked about, which are preventable, which are modifiable. So I think, and I'll turn to Jonathan really to look at why we see that there are issues in terms of that invite and then translating that into uptake. Jonathan.
Jeanelle, thank you. So maybe we should just look at invites and uptake. We started measuring the programme when it moved to local government in 2013, so we've got data from then. We've issued 29 million updates, or local government has, and some 13 million people have had a health check. So about 40% of people who are invited actually come through. So I think we've got 2 things that we really care about in trying to drive more people getting a health check and more people being followed up. One is, as the NAO have talked about, can we get sufficient offers out to people? Actually, last year, this is going to get. We measure this in a really confused way. You've spotted. So 20% of the eligible population should be called each year. So that over a 5-year period, 100% is called. Makes it very confusing to have these conversations because all the numbers sound wrong. Last year, 22% of the eligible population was offered an appointment. So actually, local government last year doing a good job of getting out the sort of numbers that they want. Now, of those, about 40% took up their appointment, their offers. So we're covering. It's 8.8% of the eligible population had a health check in 23-24, which if that was the same over the 5 years, we get to 44% coverage, which are the numbers the NAO have. So I think we've got we're doing a reasonable job, our local government is on offering people. The real challenge is, can we get people to take them up? So there's a section of why, as Jeanelle says, it's really valuable for people. It really helps you understand your risk. Of the people I think have a health check, I think 95% of people have 1 modifiable risk factor. Somewhere in the 70% of people have 2. If we look at the 1.4 million that we do a year, some 70% of people then have a brief intervention trying to help them think about what they could do to reduce their risk. You know, maybe that helping with their weight, alcohol, smoking. A very significant proportion then actually get referred on to primary care for further clinical investigation. So about 40% of people, and of those, 10% of the population actually get clinical management. So We know it's important. The question is, can we get people to really think about, will they take it up?
But Jonathan, the National Audit Office, their report actually stated that out of the, I think it's 6 recommendations, 2 of them you were able to meet adequately, but the other 4 you were not meeting the recommendations.
These are the recommendations from the 2021 review, our own review. So we commissioned a review of Health Check to understand, is it working? And actually, it's a really important piece of work, both in the evidence base that it looked at, which I can talk about. I mean, we took 12 million records out of primary care longitudinally and looked at, could you see any impact from the health check? And that has shown us that we think the health check's effective, it reduces the number of heart attacks, it reduces deaths. There's some suggestion that actually wider risk factors are also reduced over that period. So it's a really detailed piece of work. Its recommendations, there are 6 that broadly were about, can you make health checks more available and perhaps in ways that people will find more attractive. So those are the things that we've prioritised, and we've done 2 things. We're working on a digital health check so that people can do it at home at their convenience, including having much of the cholesterol testing, the blood testing sent to them at home. So that's quite an innovative programme. We'll be working with 3 local authorities over the beginning of this year to try and pilot that. So I think it's Norfolk, Lambeth, and there's one other which will come back to me. Medway, thank you. So really looking at 3 different areas. Does that make people more likely to carry out the health check? And would that be a way that we can make it easier for people to take up? So that's one. The other thing we've done is looked at, rather than sort of asking people to come see their GP or pharmacist, can we just arrange for the health checks to happen at work? So again, we've worked with 48 local authorities. We're aiming at doing 130,000 checks by the end of this March. And we have an evaluation in place to come back in the summer and say whether we thought that was effective. So we're really trying to look at what are the ways of really reaching more people with the health checks. And I think as we look at local government practice, clearly local authorities are, they're responsible for the health check, they make their own decisions. There's a real variety of practice, and actually learning from the best of local government in how they have managed not only to up the numbers of people having a check, but really reaching the communities that we think are most at risk, I think is the next big piece of work that we need to do.
Right, great stuff. So what we'll do is we'll move to the next bit, because the people around the table will dig deeper into what you have just said. There is a lot to unpack in what you've just said. So what I'm going to do is move across to Deirdre Costigan to ask your questions.
Thanks, Chair. You got it right first time, Deirdre.
Deirdre, I did get it right. Thanks,
you got it right first time, Have faith. Thank you both very much, Jonathan and Dr. Gruchy, for coming today. And we've heard some really interesting evidence from Tower Hamlets and Cumbria previous to yourself, which I think has given us some good background about how this works in practice. But Dr. Gruchy, you said there that cardiovascular disease is a disease of inequality. You've quite clearly said that, and you've said yourself, and it's mentioned in the NAO report, that more deprived populations are 4 times more likely to die prematurely of cardiovascular disease. And it's also a disease which some communities from particular ethnic backgrounds are more likely to die of. For example, the South Asian community, and my constituency, Ealing Southall, is a very high proportion of South Asian constituents. And diabetes is another issue there, which is another kind of factor in cardiovascular disease. But looking at the NAO report, do you think that we're actually reaching enough of the people who are actually more likely to die prematurely of cardiovascular disease?
So I think we would agree that we definitely could do more, and working with local government could do more to do that. I was a director of public health for 14 years, and so I certainly, when I was a director of public health with other directors of public health, would be absolutely cognizant of those inequalities, and how do we both ensure that we provide that universal service, but ensure that the uptake is greater in those who have that greatest need, which you've talked about. So I think there are different ways in which different authorities have tried to do that. And I think that sharing that learning between different authorities is really important, and OHID regional teams and regional directors of public health are able to also provide quite a lot of support in terms of looking at who, encouraging and enabling local authorities, or encouraging them to look at who's actually taking up the health check, and then doing something different as a consequence. So I think that whole process of that support, challenge and support, is really important. And then I think in terms of OHID, and Jonathan talked about the review, we've did a segmentation piece of work, so a huge piece of work looking at who are the different communities and why, what kind of segments of population that understand or are interested in, think they can do something about those modifiable risk factors. And then how can we ensure, or how should the programme and the way in which it's delivered, the way in which we try to engage those communities, how should it adapt in a way that makes sense to those particular groups who are less likely to take up the offer and then do something as a consequence. So I think that's really important. And then I think there's starting to emerge a diverse way in which the programme might be delivered. So local authorities are increasingly using GPs, using primary care, but also using, say, pharmacists, and that's quite an important way in particular communities, perhaps easier to access, less threatening. So use of pharmacists, use of other community, voluntary sector organisations to really reach in and have those kinds of conversations with people in those particular communities who just might not want to come forward and take up the offer.
Yeah.
Do you want to add anything?
Just a couple of, I think, broad points. So I think this is a real balance. So CVD risk is broadly spread in the population, which is why we started with a process of trying to call all people that weren't currently being managed for CVD to capture as much as possible.
So could I just interrupt you briefly on that? Just that seems to go against what we've just heard, that actually it's more likely to be a disease of inequality.
It is broadly spread, but in some of our most disadvantaged communities, there is much higher level. So the risk is higher, but it's not that all of the risk is in those communities.
No, of course.
So this is the tension, I think, in the programme. The original setup was, let's call everybody in as they reach 40 and see if we can change behaviour across the whole population. I think that's a legitimate thing to try and do. But we have also thought, right, well, actually, how do we make sure we're really targeting our efforts on those who are going to benefit the most and have the most need? Which, again, so I think the balance in how we do those things is important. And I think one of the things that we've seen is that actually quite a lot of the opportunistic testing is really helpful for targeting to communities. So if you turn up in the shopping centre and ask people to have a health check, they'll do it there and then. You find a reach that is different from if you send them a text message or a letter. So I think it's not just, targeting, not targeting, but actually what approaches do we use and how much of it is the sort of writing to people, inviting them in, how much of it is being in the place that people are in. And frankly, will our digital process allow us to just be present whenever people think that they're interested in their health and they're motivated to do it. So I think we've got to really think about how we're getting to people and really giving people a chance to engage on their terms and not just a sort of one-size-fits-all programme.
And I understand the point you're making, but I guess the hard fact is that even though we're saying it is a disease of inequality and there are particular ethnic groups who are more at risk, you are more likely to get a health check right now if you are more affluent. So basically, the least, the most deprived people are least likely to get a health check, whereas the more affluent are more likely to get a health check. So that
goes back to the points I'm making about how do we offer them.
Yeah.
So I don't think it's true that you're more likely to get the letter if you're more affluent, but there is higher take-up in more affluent communities. Mm-hmm. So again, I think this comes back to, are we really thinking about how do we make that offer and are we making it easy for people to take this up?
And what's the driver for that then? Because at the moment, like you say, the target that you've got is everybody over 45, so it's an age-based programme. So is there actually not only a health reason, but also a value for money case as well, for using the limited resources you've got to target people who are more at risk?
I think over 40 was basically chosen because that's when your risk starts to increase. Actually, one of the things the review in 2021 looked at, that in some communities you would be offering it earlier. So CVD risk in the South Asian community, as you've said, is much higher. Actually starts to manifest itself earlier in life as well. So there are questions around, actually, for some communities, should we go earlier than 40?
And then what's the thinking on that at the moment? Is that being assessed actively?
We have really started on trying to broaden our access. So can we do it through work? Can we do it through digital? That's where we've put our focus in the last few years. We now have the NEO report. The Minister is very taken with it. He's asked us to look at all of the recommendations, so we'll be looking back at these. And of course, the government's already made its commitment to reduce CVD mortality by 25% over 10 years as part of its shift to prevention rather than treatment. I'd expect this to be a significant part of the 10-year plan as we get to that in the summer. So I think this is a real focus for how do we reduce CVD risk. As Jeanelle says, 70% of it is due to modifiable risk factors. Our real challenge is exactly how do we spend our money and how do we make sure that all of our communities benefit from it.
Right, and if I could just move on to how the service is commissioned. One of the issues that we've heard from the Professor Everington and Dr. Wrigley that we spoke to previously was, I suppose, this tension that we've got between sort of some health-related, prevention-related stuff that's commissioned nationally and others that's kind of focused on locally. And actually we had a slight difference of opinion, I think, as to what would be the best approach. But one of the issues is that there isn't the levers currently with the funding coming through the public health grant, which has been much reduced, which local authorities are in control of, but need to consider whether they might need to spend that money on, I don't know, temporary accommodation because the system is breaking at the moment. And not having the national kind of targeting or push to sometimes allow that focus locally. How do you think that the current commissioning system is working, and do you think it's fit for purpose and is going to help us, crucially, to achieve that targeting that we need and get to the people who are most likely to be helped by health checks?
So, I'm sure we'll have views, not least as been a DPH for so long. Again, I think this is a real challenge because we're trying to balance different things. We would like everybody to benefit and there be a sense of more national consistency, but also we really want to be able to tailor locally. I mean, as we're talking about, can we reach the communities that don't really engage with our services? Your best chance of doing that is doing that locally. So I think there's lots of advantage of having a locally commissioned service for the health check. Clearly, it needs to dock in with the NHS services, and we need to make sure that we are, the GP contract, which basically pays for the follow-up care and incentivises it through co-op, needs to be fully aligned with CVD prevention. And indeed, if you think about what we've done the last few years, we've added new measures on CVD prevention and we've taken other things out. So the GP contract is going to be much more focused on this, and I would expect that to continue over time. In terms of local government commissioning it, I think it brings real advantages of the DPHs being close to their local communities. They can think about different ways to do it. Obviously, they then have to work with the NHS, so there's complexity. But if you swapped over and said the NHS commissioned it, then I think they'd still need to work with the DPH and local communities. So I think this is just something that needs to be worked out locally in partnership between health and local authority services. Levers. Local government has lots of levers to make it happen. I mean, the real question is prioritisation and spend, I think. If you look,
could you just give us an example of what those levers are?
So the way that they secure the health check programme for GPs through pharmacists is they buy the activity. So they have the most direct lever, they pay for it. So I know there's bits in the NEO report saying they've got no sort of formal leaders to tell GPs to do things. But actually, GPs, vast majority of small businesses, they have a conversation about doing work for, so I think that's perfectly reasonable. The question is, are we collectively prioritising the health check, and are people making the same decisions? And again, the report is very clear that different local authorities have taken different views on how much they prioritise this. And indeed, we've seen some authorities really change their performance. So Salford is a great example, that till very recently was quite a low performing local authority. They have put in place a new package of public health interventions through GPs with incentivisation for getting paid more for the more you do, and that has seen their performance massively improve. So I think there's quite a lot we could do about not the system, if you like, and the broad architecture, but what's the practice, what works, and can we learn from people who've been successful?
So the NAO report did recommend reviewing the value of commissioning health checks through local authorities compared to NHS or a kind of different system. Will you be doing that review?
We will.
Or have you already decided that we're going to stick with what we've got?
Mr. Gwynnes has asked us to look at all of the recommendations. He's very open-minded about it, so we will do this work. I think I was simply trying to reflect. I don't think it's a straightforward question. And there are advantages that come from local authority commissioning as well as from NHS, which I'm not sure quite comes over in the NAO report.
So could you say that last time?
I think the NAO report sort of suggests that it would be a very simple thing to do, and there are obvious benefits from having NHS commissioning. I don't think it really talks about the advantages of local authorities and the DPH in this process. So we will look at it. I think we will need to make a decision. There are arguments for both ways of doing it. I do think there are very clear arguments for improving practice in how we deliver health checks, as opposed to necessarily changing the architecture of the system.
And is there a timeline for that? Because in the meantime, there's still concerns, I think, of like a postcode lottery, basically.
We are getting on with that work now.
But what's the timeline for that, other than?
So the teams have started. I haven't got a clear date for a finish for you.
Would it be useful, Chair, if we could just, perhaps you could get back to us on what the timeline is for it? Yep. And then just... well, I was just going to ask you about the operational considerations for changing how they're commissioned. So if you do this review, do you have any feel right now? You've said that the NEA might have, I suppose, a slightly simplistic view of how it might happen. What would the kind of operational, logistic barriers be if you were to change that?
Well, look, if you actually want to change it, the first thing you have to do is take the money off local government and give it to the NHS. I think the amount of money spent is it's around £60 million, I think. So it's not a significantly large number. Then there will need to be instructions to the NHS to do it. I think the bit that I'm sort of more worried about than sort of those, if you like, practical things. I think it's really important that the directors of public health, the people thinking about health inequalities in their communities, are part of this programme. So even if you were to change who's the lead commissioner, I think you'll still end up with the same people around the table trying to work out what the right answers are.
What if it's ICBs rather than local authorities?
Well, currently the local authority holds the money and buys it from local NHS providers largely. I think 50% of all local authorities only buy health checks from GPs. 70% or so are buying the majority of theirs from GPs. So it's not as if this is a local authority service that's somehow running off away from the NHS with no coordination. I mean, this is something done jointly in practice. That would need to stay. So again, look, we will look at the NAO's recommendation. We will take, we'll talk to local authorities to the NHS, see what they think, and if we think that come back with the proposals, Minister, if we think that actually making the formal change of who the lead commissioner is effective, then we obviously can do that and look at that. I think we will find lots of operational things about how it works being easier to do and quicker to drive success. So I think we'll look at that as well. But I'm sort of prejudging the work now, which is difficult.
Just before I bring Andrew in, Danny and Dr. Becky Cooper wanted to ask two quick follow-up questions. Danny, over to you, and then straight on to Becky. Thanks.
Thank you. It was just to follow up, because I don't think I kind of heard a clear answer. In terms of dealing with failures in the programme, and I use the word failure because looking at the NA report, in some former CCG areas, 0.1% of the eligible population took up the check, compared to 22.6% in the best. And I can't think of local reasons or localism being acceptable justifications for that, why only 0.1% would need the health check in certain areas. In terms of addressing that failure in the programme at the moment, what are the mechanisms that centrally you in the DH or colleagues in NHS England actually have to address that unacceptable variation? Or conversely, if it's an issue that local commissioners are unable to change their system, what mechanisms do they have to bring about change at the moment?
Yes, I think the example of the very lowest performance, I think, is the Isle of Scilly, where they'd been relying on one GP practice that had then had some challenges.
There's a significant amount below 5%. Ignore the Isle of Scilly, no offence to Isle of Scilly, but there's a large amount below 5% compared to 22%.
So first of all, it is a duty of local government. So the responsibility in law is with local authorities to provide the health check. So that is there. It's also a required service under the public health grant, so they are expected to provide a service. We have worked through our regional offices and our regional directors with local authorities to try and improve their performance, to challenge where we see very low levels of performance and see what can be brought on. The support of the local authority and the DPH for the programme is significant in driving whether they're successful or not. Actually, I'm not sure it comes out in the annual report. This programme was deeply controversial when it was launched back in 2009, and I think some of that is still there. So actually, one of our challenges is, do we all believe this is the right thing to do, which I'm hoping the current NAO report will help. I mean, it's very clear we could do more, but it's not questioning the basis of the programme itself, which was the case in the late 2000s. So I think that there's a question of how do we work with. What we have been trying to do is both set standards for what the health check should look like, and there's good practice guidance and indeed technical guidance that we produce for that. The DPH and our regional directors have been trying to foster relationships for what works in practice and try and build that. And where we get the worst senses of we really don't think anything's doing, then obviously conversations are had about actually this is one of your statutory duties. Now, could we do more on these things? Almost certainly.
Are they standards mandatory? Are they advisory guidance? Or
it's guidance.
Okay.
So
should they be mandatory as part of the programme?
There is the legal requirement is there on local government to provide this
mandatory as part of the programme.
Again, I think what we're really interested in is how do we have the most effective programme. I think we are still learning about how you reach the communities we want to do, and I think some level of variation in how it's done is helpful as long as we're using that to learn and drive.
It seems to me, to just finish up because time's due, the amount of variation in the programme is not currently acceptable variation. Yes. It's not about localism. From what I'm seeing, as my colleague Deirdre said, we're not reaching the right people, and the amount of variation in performance is unacceptable, I would say.
Yes, and again, Andrew Gwynn, our Minister, is very clear that the NAO report, he agrees with their recommendations and he wants us to look at how we do this. So the whole question of how do we address that variation, I think, is the forefront of our minds.
Right, we'll stop there. We'll go straight on to Dr. Becky
So
Cooper.
quick, I know, yeah.
And thank you for that, Danny.
Very
Becky?
quickly, do you think this should continue to be a universal offer?
So, look, I do think there's a balance in this, that there is advantage of getting as many people as possible. We are not, as a country, a healthy population. As I say, the people who've had a health check, 95% of them have at least one risk factor. 70% of them have a brief intervention to try and improve their behaviour. And then, we're finding 11% of them actually need clinical management. So there is significant risk. So I am keen in how do we find ways for as many members of our population to really understand their risk and to take care for themselves. And so I think that is important. That said, we really must be trying to focus our attentions on reaching those at most need. So we need to try and do both things, which...
It's a beautiful political answer, thank you so much. But on balance, would you, if you have a limited pot of money, which you do, would you favour making this as a targeted programme?
Look, I think to answer that question, I'd want to be very clear on what we thought the benefits were and the evidence for those. And maybe Jeanelle might want to give a public health view at this point.
Yeah, I mean, I think it's a good challenge, and one needs to keep on going back to the evidence base. And I suppose there's a trade-off, isn't it, between universal or targeted. And I think that's also something that we will be looking at again. At the moment, it's not clear-cut. And I think the point, and the NAO report shows, figure 6, I think, is a really good figure, which shows that mortality rate across all deciles. It's 1 in 4 people die from cardiovascular disease. So it's not the case that it isn't in particular communities. We need to reach into all communities, have those conversations about their level of risk and what we can actually do about it. But we also know if we're not reaching into and prioritising energy and effort in those communities who will benefit the most, that's a problem. So I think we need to do both and. One of the issues, and it might come up in subsequent questions, is around that data to understand, well, who exactly are we reaching? And the assumptions about perhaps who we're reaching, who we're not reaching. Local areas will have some of that information, and they may well be already within their universal office targeting in particular ways, so particularly contracting particular community pharmacists in particular communities, for instance, or they might be doing opportunist screening events or contracting community champions or VCSE to work with particular communities. So I think within the programme and the way it's delivered in local areas, I think you'll find that there's a universal offer, but effort also put into in trying to get to those communities who would benefit from it most.
Thank you, which is interesting given our previous GPs who were here who were very much of the opinion that GPs should be delivering the health check. So it's interesting to hear the different perspectives. Thank you.
And I have to admit, because you started the conversation saying the way it was measured was really quite awkward, so it's 20% each year over a 5-year period, and then you say it's a universal offer, and then you say within that universal offer it's a limited pot of money. All of it begs the point, should a decision not be made, as Dr. Becky Cooper has said, that if it's a universal offer, I mean, if it's a pot of money that we've got, should it be a universal offer or a more targeted service? And you've given some very interesting answers, but to be honest, you've not answered the question, in my humble opinion. And
that is perfect. So the reason for that is we've not got to our answer. So we are doing work on this to try and conclude. At the moment, you're working it through, and an answer will be delivered at a future date. Yes. And I think what we just try to reflect is actually it's quite a difficult question.
Right. Excellent. And on that lovely note, I'm going to hand straight over to Andrew George.
Thank you. As the MP for the Isles of Scilly, with a population of approximately 2,500, I mean there are a number of anomalies that often apply to the Isles of Scilly, and
doing much better on health checks, I must say.
Exactly. And I suspect there's probably something within the methodology with regard to the reporting that might explain it, but I'll raise it with the GP when I'm
simple chance. Not very much in the way of very small population.
Of course,
so small healthcare service. Actually, I think issues with primary care not having enough capacity meant this fell by the wayside for a bit. It's now been fixed. I think it's the short story.
Coming back to, if you like, the wider geographic view. I'd be interested to know, given the difficulties, obviously you're not proud, and I'm not saying you're fully responsible, but you're not proud of the response rate to the health check take up, or the take up levels. What if you like, lessons can be learned from those health programs which have been a success? I mean, I don't have these figures before me, but I don't know. Say, for example, the COVID vaccine, or other types of rollout, whether it be bowel cancer tests and other methods. I mean, can any lessons be learned, or if you like, are there health programs of which the department is proud, and which you can say we've had a great success here, and can you not apply the lessons from there to the rollout of these tests?
That's an excellent question. I'm sure Jeanelle will want to come in on the technical. Let me have the first go. So first of all, I am proud of the health check programme. Although I do think we could do more to have more take up. So that bit. I think the real difference between health check and, say, vaccinations or our screening programs is the health check's really about helping people understand their risk. So we're not finding an existing disease and treating you for it. We're finding that actually you have got a higher risk of CVD developing over the next 10 years. And at some level, that risk is actually you need to do something about it, change your diet, maybe lose some weight, stop smoking, drinking. But for some people, their risk is sufficiently high that actually the health service would like to do something about it. And, we get into managing your hypertension or your cholesterol. So I think in some ways, it's a more difficult pitch to the public. You're coming for a health check, we might want some behaviour change, than actually we're going to test you for a screening program for breast cancer, say, where it's very clear what you're going for. So I think there's a challenge there in the sort of communication and what it means. And then I think more broadly, that leads to think about, well, how do we do that? How do we get people to engage? So Jeanelle said earlier, we've done some work on trying to think about what people think about health and do the different people in our community think differently, and does that mean you have to engage with them differently? So that raises questions for us. And again, this comes back to, I think, trying to have just a more broad way of offering the health check.
But I mean, in each case, of a successful program, you get them through a door, or you get them to a place, or you get them to try something.
Yes.
To get the process started. I mean, I think the problem that you're having is not even to get any kind of response, isn't it?
Yeah, so I think the original setup of the health check, we send you a letter, we ask you to come in, is very like a screening programme. And look, we've got, 44% uptake. I think our screening programmes are more, 70s and 80s%. I would need to confirm. So it's that simple process isn't getting the same results in health checks as it is in screening. And I think it's because it's not as clear why you're going. So that's one of the things that we are...
It's a communication issue.
I think it's partly a communication issue.
You aren't expressing it clearly enough, or what's happening?
I think it's deeper than a communication issue. So I think the member of the public receiving the letter has to understand why it's important to them. And I think that is more difficult to do than simply saying we're screening you for a particular disease. So I think there's a challenge there. We have seen success with local authorities organising pop-up opportunity sessions where they go to places where people are and ask them if they like a health check, and that seems successful. We're hoping that the programme on workplace testing will also be successful in that you go to work, people are there, and they just take it on. So I think that this range of how do we get hold of people rather than just writing a letter and hope they respond, I think is quite an important part of our process. Jeanelle is itching to come in, and I'm sure she's got much more sensible things to say, so I'm going to shut up.
Well, yeah, I mean, I think there are two things, and that's true of any screening programme as well. I mean, I agree with Jonathan. It's more complicated and complex because what we're trying to convey to someone is not whether they've got a cancer that they didn't know about. It's more, you've got an increased risk of potentially in the next 2 years getting this thing called cardiovascular disease or having a heart attack or stroke. And you can do something about it, but you need to do something about it, potentially. And so I think there are two things, and like I say, this is true of screening. One is they don't understand, which Jonathan has mentioned. And the 2021 review kind of articulated all of this, went into it in a lot more detail. They think they don't need it. They don't want any bad news. They don't want to be told off. So, look, I smoke and I'm a bit overweight. Why would I go to the GP to be told that? I genuinely just don't want to. And so it's quite difficult because it's those kinds of elements. So there's something about people's understanding of what it is, and that's where the segmentation is important, because it broke down different groups of people, and it said, well, those who are going to come anyway, fine, they'll come. But look, this is the thinking that goes on in groups of people who are not going to come. This is how you might want to, as you say, communicate differently, and kind of encourage people in a different kind of way. So that's the first thing. And then secondly, there's around access. And I think Cornwall, for instance, will have a big issue because it's much more rurality. So people to actually bother to get in the car or leave work and go for a health check need to really be kind of invested in going and then having that conversation and then doing something about it. So I think there's something about that accessibility, and that's why the supermarket example is about how we break down some of just that pure accessibility. And we know that screening programs where you get something through the post and then you send it back is bigger uptake than actually having to go to a breast screening, for instance. So there's definitely something about just that physical access, and I think that's why we're hopeful that the digital will really enable people to do it at home, and that will increase the accessibility. So I think that's why the digital program is really important, and also that it will encourage a bit more over time engagement with one's sense of a level of risk of getting cardiovascular disease. Okay. So what we need to do with the digital program is make sure, and that's built into the way we're going to evaluate it, that it does actually get to those communities where it could actually, so it doesn't disadvantage, it does increase people's access, because I think that's a really important part of it.
So when will you know? I mean, if you're rolling it out in Norfolk, Lambeth and Medway, three areas at present, I mean, it's kind of well known, isn't it, that the most digitally enabled are those who are your high take-up groups, and not the target groups that are most at risk. I mean, are you not fearful that pursuing a digital methodology is actually just going to reinforce a much higher take-up? I mean, not that that's a bad thing. A much higher take-up of the group that perhaps is at less risk, but a lower take-up amongst those who are at higher risk.
So I think it definitely needs to be evaluated, and I think that's the idea. Equally, though, it could increase the access for people. We know all over time, increasingly, people are much more digitally savvy. And I think it also will enable us to be more bespoke in terms of the messaging and the nudging and the links through to actually think about behaviour change and what the ways in which people might be able to change their behaviours. I think it provides much more opportunity for that, and certainly over time one can much more quickly adapt and change it based on the feedback about, we'll have a lot more better data about who's taking it up, and therefore really, as you say, be alert to who's taking it up, who's not taking it up. But it's not a replacement for the face-to-face. It's just an additional, and it might help then in terms of some of the universal or targeted, and where you then are able to put more money and energy and effort in terms of really trying to ensure that the uptake is...
So will those who receive the invitation to undertake a digital checkup be invited to undertake a face-to-face as an alternative?
Yes, no, I think it's an additional, but I think because it's in 3 pilot areas, we'll be exploring those ways in which it's
the
delivered.
aim is to try and make a digital one available to expand access, so more people can take it up, and people who are interested in their health can look for a health check. I think we have something in the background to make sure that you're not having endless face-to-face health checks through the process, so that everybody gets it rather than just a few people. But as Jeanelle says, the aim is trying to open up access to more people, which indeed could mean that then the local authority commissioned local services can become more targeted if we get lots of people through the digital. But we don't know yet. So 3 authorities being piloted, the NHIR are doing a formal evaluation, so we'll really get a sense of, does this work? And if it does, that's coming.
When will you know? When will we get?
I believe that's coming this year as well. We're doing the pilot in the early. It's into early next year.
Early next year.
On that note, thank you very much, Andrew. Can we bring Dr. Anna Dixon straight in to ask her a question? Anna, you've got about 12 minutes.
Okay.
Well,
I'll
see what we can do.
I'll encourage our witnesses to also be
well,
brief.
we will
speed
them. We will speed them up if they're going round the bushes a bit. But over to you.
Thank you very much, Chair. And before I get into questioning, I declare a conflict of interest that I worked at the Department of Health with Jonathan earlier in my career before coming to this place. So I'm going to pick up the issues of data and evidence base. As you might envisage, as I'm guesting from the Public Accounts Committee, quite an emphasis on value for money. So the NAO report says the lack of data prevents DHSC from having a national understanding of whether people who are at most risk of CVD are those attending health checks and whether people are accessing services or clinical support to help them reduce the risk. So, without data such as age, gender, ethnicity and socioeconomic status being routinely collected and shared, what information have you relied on to ensure that the programme is delivering value for money, and by that, I guess, including reaching, as we've been discussing, the people who can most benefit?
So the data we have most relied on is the data that was collected for the 2021 review, which basically pulled 12 million records out of primary care and looked longitudinally at the experiences of those people. So
You're not routinely.
So I think that establishes a very clear evidence base for the effectiveness. So I think that gives us great evidence that this does behave as we expected. You are right, we do not have routine data to that level. We are currently working with our National Advisory Group, with local government and with the NHS on what improvements we think we can make to the data, particularly thinking about can we get more information on who's receiving it, ethnic group, the kind of data you'd expect to have from sun targeting. So that's something that we are actively working on. And as you will fully appreciate on this committee, the wider set of information sharing challenges between local government, the NHS, primary care, DHSC continues to be something that we work on broadly. We do not have routine access to the GP record in the way that some might expect. So actually, when we're trying to do in-depth research, it tends to be these one-off projects rather than being able to look all the time. So a much bigger question about data there.
Yeah, so obviously, again, be useful to understand whether that's going to be part of this review you're talking about in response to the NAO and sort of what the timelines would be, because it seems very difficult for you to drill into best practice if you don't actually have data on who's performing well on a real-time basis, as opposed to, as you say, these one-off studies. You talked about the evidence base in the 2021 review. Can I just check in terms of cost effectiveness, what we were able to establish about the cost effectiveness of the programme?
The ROI of the programme we established, we think for every £1 we spend, it pays back £2.93.
And does that include all the costs of the follow-up?
Yes.
Okay, so just coming to some of the data around integration. You talked there about some of the lack of collection of data, but then also the sharing of data. That needs to obviously not only be on who are you inviting, who's then subsequently attending, but also what follow-up do they receive. Will you be able to track that right through to then what the outcomes are as a result of that follow-up? You talked about, for example, 70% brief intervention. Do we know whether, having received a brief intervention, whether people do actually change those modifiable risk factors?
So the detail of our understanding comes from that study where we looked at 12 million records. So that's our best evidence base. In terms of following locally, wherever a third party is providing the health check, so not the GP, there's a requirement for them to share information so the GP can continue to track and understand what's happening with their patients to avoid risk. We've done lots of work with local government, including PHE have published guidance on data sharing on what information can be shared for management purposes. So anonymised information, obviously, which is much easier to share across the boundaries of organisations. We've done lots of work there. I think some of the questions we start getting into, you would need patient identifiable information, and that's much more difficult. So these are some of the things we're going to have to think about as we address those recommendations.
Okay, so in the NAO report, it specifically mentions this data set of CVD prevent. We also, in addition, from our earlier witnesses, heard about the potential for patients to input data through something called AccuRisk, which I believe is quite prevalent within general practice, and also other tools that would help primary care to target whether that be health checks or subsequent interventions by embedding QRisk3, which is academically developed risk scoring system. Can you just sort of say what you're doing around these sorts of opportunities for better data to help support the prevention of CVD?
I think CVD Prevent is really exciting. So this is a national level clinical audit of primary care. So this is using the primary care data to look at essentially CVD risk, levels of treatment and under treatment, So really getting who's being treated. So I think it gives us a chance to really understand what is happening in practice. So I think that will be a very powerful data source, and really looking forward to working.
Can we link any information on health checks into it? So the sort of thing that you had to obviously commission in 2021 for a very laborious process could actually be embedded within that audit. And so again, on an ongoing basis, we would be able to understand the value of people having had or not had
this is one of the things the NAO have recommended, so it will be one of the things that we look at. I think it is not included currently. No. So really it's looking at the management of CVD in primary care. And remember, it's not only health checks that finds people with CVD risk. You know, GPs will be doing that themselves. Actually making the connection to the front end, if we can do that, I'm sure we'll add further information on the effectiveness of the health check programme. But as Jeanelle said at the beginning, really we're trying to prevent CVD, and the health check is just one part of helping people understand their risk, and some people being funnelled into primary care services.
I might come to Dr. Gruchy. Obviously, you've talked quite a lot about what more could be done to understand uptake and the different approaches. You've talked quite a lot about the workplace and digital as new areas. I'd encourage you to also think maybe about job centres to reach some of the people there. Obviously, there is this step that it's no point identifying these risk factors if then nothing sort of happens as a result. And the data here on sort of treatment seems to be very largely around more biomedical. Again, we were hearing from previous witnesses about the need for sort of a more holistic approach, for example, the use of health coaches or social prescribers in primary care rather than just a GP patronisingly telling people, which I'm afraid sometimes a brief intervention we know is just that, and we know that's not very effective. So alongside that, you're spending a large amount of money, NHS England, on national diabetes prevention, various things around tobacco and alcohol dependency and weight management programmes. So again, in this point about evidence and data, how are you assuring yourself that this, even where you are getting attendance and detection, that you're actually getting improved management? I know you briefly said, but I'd like to hear a little bit more about how do we really know that the follow-through is effective?
Yeah, I think that's a really important question. By the way, I just wanted to pick up briefly on QRisk 3, because that is the programme that is fundamentally part of the NHS health check. So that's how the risk is determined. So it's a bit different, I think, that perhaps some of the other programmes that might have been mentioned. So I just wanted to clarify that. So I guess that then takes your modifiable risk factors, the 6 modifiable risk factors, develops through QRisk the score that you most likely, your level of risk of developing cardiovascular disease in the next 10 years. And then I suppose it's down to that interaction to motivate you to then seek help to modify those risk factors. So I suppose it goes back to what I was saying about people's understanding both of that level of risk and their tolerance of whether they are or aren't, their belief system, whether they think that's going to happen inevitably anyway. So there's a lot that goes on to whether they then will take up a smoking cessation service, a weight management service, or become more physically active. If those services are available, they're accessible, the referral process is easier, you would think that the person is much more likely to actually take up that, because it's both what they think, their belief, how they're spoken to and encouraged and supported, but then also the accessibility. So I think that follow through is really, really important. That being, the fact, the link to GPs though is also really important in terms of the clinical risk factors. So if you've got high blood pressure, really checking to see whether you've got hypertension, need treatment, and then if your QRisk score is over 10%, being offered a statin. Those are important. But also the follow-up of those clinical interventions, I think, is quite important, because we know, I don't have the figure to hand, but there's a big drop-off of somebody being prescribed a hypertensive or a statin as to how long they actually stay on those medications. So there's also a question about the effectiveness of that secondary prevention through primary care. People's understanding, again, that they might not have a visible symptomatic condition, but they have to take, a drug for a lifetime. So there's a lot in it in terms of how we engage with people, how we support them to be the healthiest that they can be, to reduce those risks.
Yeah, it's just very briefly, I think we do really well on understanding the clinical management of these risk factors. So where you have hypertension, atrial fibrillation, higher cholesterol, we've got great data through GPs and we're driving improvements on those. I think that is good. I think the questions you raise about what are we doing on much earlier primary prevention, helping with behaviour, I think there's much more to do. I think the diabetes prevention programme, which you did mention, is a real highlight of what we've done over the last few years. And so this basically identifies people who are at risk of developing diabetes. They're not diabetic yet. Puts them through a behaviour, weight management, eating, exercise programme, and it's seen the reduction in risk of diabetes amongst people doing it falling by 37%. So it's been really, really, really effective. I think 1.6 million people have benefited from it to date. It's one of the things that really, I think, shows we really can make a difference.
But is there any link between those effective programmes, which you are spending money on and are demonstrating benefit, and getting people whose risks are identified through health checks onto them? So I'm just concerned that these things...
The health check programme is undoubtedly driving people into that programme.
Okay, if there's data on the sort of numbers going out of health checks into some of those programmes, or what percentage of people on those programmes have come from health checks, I think that would be very useful for the committee to understand the relationship between those. Because
your final question,
my final
Anna?
question is, Chair, yes, it builds on this really. Obviously, we're looking at a 10-year plan. The government are very committed to the shift to prevention. Absolutely key that things like NHS health checks, which I know are under the public health grant at the moment, but also lots of things that do sit within NHS budgets are prioritised. That means integrated care leaders saying they have the capacity to invest in prevention. And we heard again from one of our earlier witnesses that they felt that, for example, the Department of Health and NHS England should be requiring some sort of 1% or other part of an ICB's budget to be protected prevention, so we don't continue to bail out the acute sector, as we've seen many times in the past where overspend in the acute sector raiding prevention budgets. So can you just very briefly say what discussions you've had with ICB leaders alongside DPHs to ensure that prevention activity like health checks is protected as we go into the 10-year plan?
The Secretary of State has been very clear that he sees a shift from treatment to prevention. The government is clear that it wants to see a 25% reduction in CVD early mortality over the next 10 years. The 10-year plan process is in place, both talking to the public, members of NHS staff and indeed expert groups are working on what we might do. So I think all of that is happening now, and I'm sure as we get to the 10-year plan we'll be able to explain the decisions the Secretary of State and ministerial team have made to meet these targets. I think this work is all live.
Thank you, because we're running out of time. And Anna, thank you. Excellent questions. Danny just wanted to ask a really brief question.
Very briefly.
Over to you.
Building on Anna's point, you yourself have touched upon the value you see in a variety of providers and new routes into the health check system to reach those not reached. We had slightly different views earlier from general practice colleagues. The NAA report highlights the lack of consistent data sharing arrangements as a major barrier to the programme. It seems that's quite a significant tension going forward. If you diversify further providers, bring in a digital version, as Anna's mentioned, the direction of travel for the 10-year plan is to involve more community-based provision, to push services out to the community away from general practice. How do you overcome the challenges of data sharing? The NA report specifically points that at the moment a lot relies on informal arrangements or locally derived decisions. Does there need to be more direction from the centre about data sharing between constituent parts of the health and public health system?
This answer must be brief.
So if you're a provider, let's say a community provider or pharmacist, the data has to go to the GP, so it's integrated in that way.
That's not what the NAO says. At the moment, a lot of it is manual letters being sent that may or may not be entered, or there may be data error.
So we'd have to look at how that's done, but it is a requirement, so it has to go back to the GPs. So, I mean, perhaps you're asking about the quality of that data. And I think when it refers to the negotiation, that's the local authorities needing to get the data from the GPs as providers to look at. So that's where I think a lot of that
it's both. If you want to, sorry to delay the point, if you want a roadshow delivering a check in a supermarket, you wouldn't, I imagine, necessarily have access to GP level patient data to be able to enter that live back into the system. That's certainly what, in my experience, I've seen, what the NA report I think is indicating, and what one of the colleagues earlier said was the case, and in his view rightly so, because he wants to protect the integrity of GP data. But it seems to me that a big tension against locally derived provision and a variety of providers is this point about a lack of consistent access to data systems.
Yes, I do think that, like many of the questions around this programme, it's a balance. So yes, we need to make sure the data is consistent. As Jeanelle said, there are rules in place to make sure there's safe data. Data travels around the system for local safety. Clearly, making that administratively easier is important, and we've done lots of work on trying to give broader access to the GP system so other providers can write data directly in. That's a programme that's currently live. I think our other question is, as well as the data, are we actually getting to the people that we need to get to? And I think, if that means sometimes our data flows aren't quite up to date or aren't quite as slick as they might be, but we're getting people through the health check and we're getting them back into primary care where they need it, I think that's worth doing. So it's a balance always of maintaining the data flows, but getting to the people.
Just to end it, you are at the moment looking at the processes.
We are.
You are evaluating it, and you will feed back to the committee the results of that. On that note, we're going to hand swiftly over to Becky to ask a question.
A couple of questions, okay. So I was going to ask about the broader public health agenda, but I'm going to stick with a couple of things because I think it's quite important. So the NHS health check, do you think you've got a branding problem? Because ultimately what you're telling us is that this is CVD screening, albeit picking up dementia, etc. Have you considered not calling it a health check? Have you considered calling it a heart disease screen or something? Because I think, and this is 20 years in the public health business, an NHS health check says nothing to people and it can be easily dismissed. Have you considered that? Have you thought about actually we need to be much more effective in telling people what we're doing here?
So it's not a screening programme.
I know the screening thing is tricky, Jeanelle, I understand that, but there is something more specific that could be said about what you're doing here.
So just can I check? So is your point about what it's called and then how it speaks to people?
And how it speaks to people. Have you considered there might be a blocker there that health check says nothing, essentially?
I mean, we could look at that communication. It hasn't come out specifically, but it's certainly something worth looking at. But it's more, so in terms of what it's called on the package, as opposed to how it lands with people.
Yeah, and I think just want to add the 2021 review, one of those 6 recommendations was actually that we should think of a broader range of conditions to be in the health check. So I think we've got 2 things here. If it is really about CVD and that's all it will be, could we communicate that better and would that reach more people? Or actually, is the long run this will become a broader health check, looking at a wider range of risks? And I think that's a big question.
Sure. But the branding I would recommend have a think about. And then the other issue that I just wanted to bring up was about funding. So it's £60 million, is that right?
I have written it down somewhere. It's something about order. But
fine. I mean, that is
£62 million.
£62 million. So that's ultimately a drop in the ocean compared to acute care funding, etc., etc.
£62 million for the health check.
Yes, absolutely.
So not all of the follow-up that happens after.
Fine. So commissioning of health checks, £62 million. Clearly you believe in this programme, you think that it's worthwhile. There's an NIHR report that says, this is actually doing some good stuff. Do you believe that this should be funded more substantively? Because £62 million clearly is only going to get you so far.
Also, clearly, it's a local government responsibility, so they make the decisions on theirs. They're provided with £3.6 billion in the public health grant from government to meet their local public health requirements. I think we would like to see greater take-up of the health tech. Yes, I think that, I personally would like that. I think the questions that my minister is asking me after the NEO report are about how do we drive more take-up. So I think,
Okay, so you think there should be more funding allocated to this?
No, I definitely think I would like to see have more take-up, and I think we should be looking at how we do that. Okay. That work is ongoing.
One more question, sorry, around funding, about prevention, and perhaps this is for both of you. So prevention obviously has multiple benefits across society, and we could argue primarily that it is in health, but of course it is around economic growth, etc., etc. Do you think prevention funding should primarily come from the Department of Health and Social Care, or do you think that other departments should have a prevention fund?
Jeanelle will probably do a more technically advanced of it. Look, I think prevention in that broader sense of how do we have the best possible health for our population really is a cross-government effort. You know, do we have great housing? Is our education system working? Exactly what of that you would call prevention, I think, is a more difficult challenge. But I do think we are thinking much more through the various missions that this government's adopted about are we spending our money well to drive that. The Opportunities Mission looking particularly at early years and our children ready to learn, which is both a set of education interventions, a set of health ones, so broad. So I think we're starting to do that much more broadly. And I do think within the Department of Health, we are looking at, in the Secretary of State's shift from treatment to prevention, are we prioritising the things the NHS can do itself in secondary prevention and other areas to really prioritise this work and ensure that we're getting the best possible health outcomes for people, and hopefully reducing the cost of the NHS over time.
Right, on that very positive type note, I'd like to thank you both for coming. You've answered some really quite difficult questions, and thank you. And I'd like to thank all the people that are around the table. They've asked you some brilliant questions today. Order, order.